So just a bit about the British Indian Medical Association. We're a society formed in August last year and aim to support all medical professionals, both academically and socially, during their professional life, whilst providing a voice for British Indian students nationally. So we hold many events open to everybody. So we're currently holding a specialty series that takes place every Sunday. So we're currently doing pediatrics, and next we'll be moving on to obstetrics and gynecology. But also networking and careers events. So this Saturday, we're holding a women in surgery panel discussion, and also social events as well. So please follow our social media pages. I'll link them in the chat below to stay up to date for our events. So in terms of our talk today, we're excited to be working with Quesmed. This is just the BIMA team. So we have Amar, who's the president, I'm the vice president, and then we have Sarika, who's the academic lead, and Chavini and Maharsh, who are the clinical officers. So just for the talk today, a few housekeeping rules. If you could keep your microphones muted throughout the talk, but feel free to ask questions throughout and pop them in the chat, and we can either go through them throughout the talk or at the end, depending on what Yezen prefers. So thanks, Yezen, for agreeing to deliver this talk, and I'll hand over to you.
Cool. Right, thanks very much, Sonam. Brilliant. Okay, so I'm going to share the screen, which is here. Okay, right. So people can see that, I think, and can hear me. Cool, excellent. So thanks very much. Yeah, so we'll do questions at the end, but if there's anything that's really urgent or burning, or you know, that's sort of relevant to exactly what I'm talking about, then I'll go through it if that's all right, just because otherwise it sort of slightly disrupts the flow of the session. So thank you very much for inviting me. So my name is Yezen. I am one of the founders at Quesmed, today I'll talk about neurology. I'm an internal medicine trainee, so in my second year. So you do your foundation years, your 2 years, and then you do internal medicine if you want to do a physicianly specialty. And then I'd like to do neurology going forward. So this is right up my street. I've given this talk in the past, and it was well received. So hopefully it will be this time. And what we'll be focusing on today is very much the sort of core neurology that you need to know. And yeah, again, thanks to BIMA for inviting me. Yeah, and hopefully the start of a great collaboration going forward. Lots of stuff going forward. So thanks for coming. So who are us? Who am I? Who are we? So Quesmed, we are a question bank. We have 6,500 questions. 5,500 of those are clinical. And the idea really is to try and promote the high quality learning and clinical reasoning and deep understanding of medicine, rather than just sort of rote learning, just focusing on guidelines and just sort of regurgitating facts. So really what we try and do, and hopefully this lecture will reflect, is this idea that you need to really understand, you know, why you're doing things and how to think like a doctor. Yeah, so that's us basically. And yeah, we've recently released a mobile app, which is offline, which is very well received as well. So yeah, we have lots of stuff coming up in future. So feel free to follow us on social media as well. So yeah, that's us. Cool. We run weekly events. So this is our list of tutorials in February. The one we're doing a finals mock test on Saturday, and also drug overdose the week after, I think on Tuesday, which should be forward to that one. And that will be one of our lecturers, Manjit, who's very good. So yeah, that's us. That's the QR code if you wanted to join the Facebook group, if you wanted to keep up to date with our tutorials. And then right at the end, if you don't mind, please fill in the feedback form. This is a QR code for it. I'll put the slide up at the end, just so I know if this is a useful talk for you. And then if there's anything I can change going forward. So I hope this is helpful. Brilliant. So today we are going to be talking about neurology. So neurology is something that people are very scared of sometimes, to the extent where there is about neurophobia, which is indicative of the fact that sometimes neurology is not very well taught, but also maybe there's less exposure to it. So we're going to go through these conditions, and really I hope this is very much the core sort of neurology that you need to know. And to be honest, a lot of this is I think what the problem is sometimes is that people end up going too deep into neurology and really worrying about neurology and, you know, not really knowing what to actually learn. So I hope this gives you a core understanding of what you need to know, so that you can build your knowledge going forward. So as we do in most of our lectures, it'll be mainly single best answer based. So we'll give you some polls as well, and then we can discuss the questions. Okay, so let's start with the first question. So we'll give you about a minute to answer. We'll put the polls up around 30 seconds in, and then, yeah, we'll go from there. Cool, so put the polls up. Yeah, there we go. Thank you very much. Good. Okay, so that's been about a minute. So if you'll have a look at the answer. Good. So we've got 53% have gone for A, and then 36% have gone for C, and then we have 4, 4, and 3 for B, D, and E. Cool. Okay. So I'm just going to keep it on there. Good. So let's have a look at the answer. And yeah, the answer is actually A. So we've got a 65-year-old man who presents to the emergency department, sudden onset left-sided weakness, which in the context of someone who has a past medical history of these cardiovascular risk factors, you're going to be thinking about stroke, right? The reduced power, left-sided homonymous hemianopia, and left-sided neglect. So clearly there's a lot going on, and then there is no facial weakness. So you really need to understand sort of where the lesion is, which is one of the cornerstones of neurology, and also in stroke. So this is really going at a classification which is called the Bamford classification of stroke. And it's used less so now, but it's a really good way of actually understanding the way that stroke physicians think about stroke. And although it's not used to sort of, doesn't change management in many ways, but it helps to sort of narrow down where we think the lesion is, and it helps us sort of look at imaging in a more useful way. So the distinctions here are whether or not, first of all, if it should be on the right side or the left side. As you know, the left-sided symptoms will tend to be affecting from the right side of the brain, and this is because of the tracts as they cross in the medulla. And then, so that makes it, you know, all the left-sided stuff you can remove, and then it's either going to be total anterior, partial anterior, or lacunar stroke. And lacunar stroke tends to be something that's a much more sort of focused, and can be sort of pure motor, pure sensory. And then sort of the distinction is between total and partial, which seems to be the one that people sort of were less confident with. So what I'll do is I'll show you the image first. And I'll talk about the Bamford classification in more detail when the image is up, so that I'll tell you exactly why it's total and partial. So as you know, stroke can be ischemic or hemorrhagic. So 85% of strokes are ischemic, and what you look at on the CT is that most of the time you see nothing on the CT, whereas sometimes you see this sort of hypodensity, which is sort of, in this particular scenario on the left-hand side, that looks like an MCA stroke, which takes out the sort of MCA territory, whereas a hemorrhagic stroke is seen as a hyperdensity, which we can see here, a very small white lesion comparatively, which is hemorrhagic. And the risk factors of stroke are many, as you can see, but there are certain ones that you really, really need to ask about. So the ones that you will likely ask about in a history anyways are things like ischemic stroke, hypertension, smoking, diabetes, sort of, or family history of ischemic stroke. But the one that people tend to forget quite a lot is atrial fibrillation. And this is super, super important because it's one of those modifiable risk factors that you really can reduce the risk of stroke significantly if you pick it up. So it's very important to ask about if they have a history of atrial fibrillation, checking the pulse when you're examining them, and also doing an ECG to see if there's any evidence of P waves or lack of P waves, or an irregular heartbeat, which is consistent with atrial fibrillation. Equally, with a hemorrhagic stroke, there are certain things that are important, such as age, being male, and also hypertension. But the one key one as well is you always need to ask if a patient is on anticoagulation therapy, which it may include warfarin, DOAC, and to a lesser extent, sort of aspirin and clopidogrel. But certainly, to be honest, anyone that comes in with any stroke-like symptoms, you always need to ask, do you take any anticoagulation? Because it's very high risk for bleeding, as you would expect, and one of the sort of major sort of causes of bleeding, not just in the brain. So this is what I was talking about earlier, the Banford classification. And basically the idea is that you can divide where the stroke happens according to if it's anterior or posterior and lacunar. And basically, although it's not sort of, it's used, we use it clinically and people sort of use it as a frame of reference, it's mainly quite useful as a learning tool, basically to show you sort of where things, why the stroke is in a particular area, or why we think a stroke is in a particular area. So in our patient, the patient has three different things. So the contralateral hemiplegia or hemipresis, and contralateral homonymous hemionopia, and higher cerebral dysfunction such as aphasia or neglect. Whereas if it was partial, you would have two of the above, or higher cerebral dysfunction alone. And I know this is sort of pedantic in the sense that, you probably will never really need to be asked sort of the total, if it's a total or a partial. But I think it's quite important to know generally as a feeling what is very, very severe. And to be honest, that stroke that I showed you in the case was actually quite severe. So if you were to hedge your bets, you'd probably say that it's more likely to be a total rather than a partial, just because of the severity of it, because there's quite a lot of areas of the brain that are affected. Whereas in a lacunar stroke, as we were talking about, it tends to affect the tract, so something like the internal capsule, which you may remember from your neuroanatomy, and that will lead to either a pure motor stroke, and if it's affecting the thalamus, sometimes it can become a pure sensory stroke, which is much rarer, or a sensory motor stroke in certain instances. And this tends to be the small arteries that are supplying these areas. And finally, the posterior circulation stroke, which is a bit of a it's very different. It affects the cerebellum, it affects the eyelids because it affects the brainstem, and actually it can just lead to lots and lots of different issues. And therefore, posterior stroke is much more difficult to diagnose and tends to be associated with poorer outcomes for many reasons. One, because it affects the brainstem, which clearly can be important in terms of maintaining your own airway, and may need intubation, for example. But also in the fact that sometimes it's just not well diagnosed, or sorry, it's not diagnosed early enough because the symptoms are less clear. So obviously, if someone has acute onset arm weakness, it's very clear. But if someone's a bit dizzy to start off with, then it's much more difficult to actually pinpoint. So this is the sort of classification that we use for stroke, and it's something that is a good method of understanding stroke classifications. So I hope that's helpful. Okay, let's have a look at the next question. So you put up the polls, please. Thank you. Okay, so that's fine. So people can see the results. So we have 34% have gone for B, 31% have gone for A, and then 19% have gone for C. Okay, cool. Fine. So got a bit of a mixed bag. Not too sure. So kind of a good spread. That's fine. So the answer actually here is B, which is supportive management and neurosurgical referral. So let's go through the question again. So you've got someone with difficulty speaking, inability to raise the right arm, hypertension, and then it's fully functional 3 hours ago. So we have a good timeline in the sense that, you know, he could potentially be for thrombolysis through alteplase, which some of you have chosen. And also he's got a high blood pressure-ish, and then he has the key point really in the whole thing is that he has a hyperintense lesion in the middle cerebral artery vascular territory. So basically the idea is that you're thinking, what does a hyperintense lesion mean actually in the left middle cerebral artery vascular territory? So basically what I was telling you earlier, when you have sort of this hyperdense or hypodense lesion, when you have what this is really talking about, if I go back, sorry, just I'll go back a bit. Sorry, that's bleed. So that when you have a stroke, it's a hypodense lesion, whereas in this particular scenario, it's a hyperintense lesion or hyperdense lesion. So actually, this patient has a bleed, not an ischemic stroke. Oops, sorry, gone too far. And then going back. So that's why the answer here is supportive management and neurosurgical referral, which is a management for a brain bleed rather than a stroke. If it was a stroke, you'd either have a hypo-intense lesion, which is the sort of blackness, or you have nothing on the CT. And then if that was the case, the patient would be for alteplase, aspirin, and other stuff. The intravenous labetalol, not many people chose. If the blood pressure was really, really high, if you had a bleed, then the management would be to try and reduce that. And then one of the management options is intravenous labetalol, but it depends on which stroke unit you're working. Even across London, different stroke units will use different things first. So labetalol is one option. You can give sort of GTN patches as well, things like that. So it doesn't really matter what you use as long as you get the blood pressure down. So looking at bleeds, can anyone tell me what this bleed is on the left? Any ideas? Yeah, so that's a subarachnoid hemorrhage. So the bleed that's sort of within the confines of the brain tends to be a subarachnoid hemorrhage. And what about the one on the left? So that is a subdural. It's a bit of a weird one, I think, this one. It's a bit sort of acute on chronic, because it's not like clearly hypodense, but the black stuff probably looks like old blood, and this is sort of new blood. So this is a bit more niche. And then we talked about this earlier. This is the sort of hyperintense lesion, which tends to be in the middle. And then at the bottom right, I think people are saying, yeah, so that is an epidural hemorrhage. And the idea really is that with an epidural bleed is that you've got the skull linked to the dura. So actually the way it looks like is that if you've got a bleed, it sort of crumps up like that. So that's why it's sort of quite well confined. Whereas if it's a subdural hemorrhage, it's under the dura, so it sort of all leaks out. And that's why it looks like a sort of concave shape rather than convex. So fine, cool. So that's that. Excellent, good. So the acute management of stroke is the ABCD. To start off with, if the CT head is normal, you treat as ischemic. If it is within 4.5 hours and there's no contraindication, you thrombolize with alteplase. And if the CT head shows a bleed, then you would discuss with neurosurgery and the blood pressure control. So either, as I said, IV labetalol, which is one of the options, or you can give a GTN patch. And the cutoff that we usually try and aim at is actually to reduce it by less, so you try and reduce it to less than 140/90. That's the sort of cutoff. And then if the CT head is normal and if it's not within the window, then you give 300 milligrams of aspirin for 2 weeks, then 75 milligrams of clopidogrel afterwards. But I've noticed actually that different stroke units will do different things. So I think at St. George's in London, they give clopidogrel, for example, instead. And there are some recent trials that show that you give both aspirin and clopidogrel for 2 weeks and then just continue on aspirin. So it really depends. So I wouldn't get too bogged down with the antiplatelet aspect of things, to be honest. But just know that normally we would give some antiplatelets for 2 weeks. And then if they have something like atrial fibrillation, then we would give them anticoagulation. If not, we just keep them on a single antiplatelet for life, essentially. And then you need to have physiotherapy assessments, and then if there's a large vessel thrombus on the CT, you would consider thrombectomy. So fine. But the thing is, when you're asking a patient about stroke, you need to always make sure that they don't have any risk contraindications to thrombolysis, which, as you can, I've just put sort of a list here. But the key one is to make sure that they're not on any anticoagulants. I think that's very, very important. And the very high blood pressure is important, because if your blood pressure is more than sort of 200 systolic, you can't actually safely thrombolize them. So you have to get the blood pressure down before you thrombolize. But I get that's a bit sort of postgraduate, so I wouldn't worry about it. And finally, the chronic stroke management. This is something that you may be asked about, maybe more in OSCEs. Holtz is a very good mnemonic. And then basically, if someone has a stroke and then you want to treat them afterwards, you check their blood pressure, you give them the antiplatelets, anticoagulation, which we talked about earlier, lipid-lowering therapy in the form of statins, smoking cessation, making sure that you check for diabetes. And then there are certain numbers of patients who have carotid artery stenosis, of which if they have a certain amount of carotid artery stenosis, usually between 70 to 90%, and they have sort of symptomatic stenosis, i.e. it has caused a stroke or a TIA, they should be referred to the vascular surgeons for a endarterectomy, essentially sort of take out all the crud that's in their arteries. So that's just a rough view of how we manage stroke later on chronically. Okay, let's have a look at the next question. Okay, fine. So let's have a look. So we have 33% have gone for C, 28% have gone for A, and then 15% have gone for T. B. Cool. Okay, very good. So the answer here is, in fact, C, vital capacity. And this is something that's sort of related to what neurologists think is most important in terms of what might kill the patient, basically. So you've got someone who has, who's acute onset weakness, returning from holiday in Spain. What you really need to be thinking, regardless, is that does this patient have Guillain-Barre Syndrome, which is something that is common in young, not common, but common enough that in someone who's young with new leg weakness, especially coming back from holiday, because it can be post-infectious. If you get a gastroenteritis or something like that, the key thing is that you get this acute onset muscle weakness, and basically as a result, you end up having a reduced ability to breathe in and out, and therefore oxygenate yourself, and then subsequently you might end up in ITU. So, but the thing is, what ends up happening is that the first thing that goes is the vital capacity. And that is reflective of your abdominal muscles. And then the thing is that some people think, oh, let's do an ABG. But actually, once you do, by the time you have hypoxia as a result of this, hypercapnia, it tends to be quite late and a bit too late. So therefore, the most important thing with anyone is to always make sure that the patient has a vital capacity. So that's why it's the most important initial investigation. But actually, if the question was saying, what's the next best investigation in the management of this patient, you could say stuff like, bloods, such as full blood count or potassium. But it's not so relevant in this case. I mean, of course, it's relevant that you need to do it just to make sure, but it's not the most important thing that you would want to get in straight away. But practically, it serves a problem because, of course, it's difficult to get a vital capacity sort of meter, an FVC meter, but in most emergency departments, they should have it, so you should be able to get it quite quickly. So yeah, that's why. Fine. So So Guillain-Barre is interesting. It is what we call an ascending polyneuropathy. Basically, you have antibodies that damage the nerves, and then there are different subtypes which you don't really need to know about, and that can have different effects on different parts of the nerves. So you can have a mix of motor and sensory signs, but sometimes you can get purely motor. And not so commonly, rarely sensory, but it tends to be mixed motor and sensory together. And it starts usually from the bottom and then sort of goes up, as that's why they call it ascending. And it tends to be associated with an infection. And the classic two are Mycoplasma and Campylobacter. So that's why they sort of have these, I went on holiday and I had some gastroenteritis and now I can't use my legs. So we talked about FVC. And the treatment tends to be either plasma exchange, which essentially tries to sort of remove the bad antibodies that are causing all this damage, and also IVIG, which is sort of giving a patient lots of antibodies in the hope that it tries to sort of dilute the effect of the antibodies on the nerves, and both of which are found to be helpful in reducing sort of improving the prognosis in Guillain-Barre syndrome. And the very important thing about Guillain-Barre is that you need to make sure to involve the intensive care unit very early and make sure that they're constantly monitored in the way of the FVC, but also sometimes, if possible, like a telemetry, because sometimes you can get this autonomic dysfunction where you can get sort of, tachycardias and high blood pressure and low blood pressure, and then it tends to, that can also be quite dangerous for patients. So they need to be monitored quite closely. Cool. Okay, next question. Cool. So okay, guys, cool. Let's see what people think. I think most people straightforward enough for. So 73% have gone for B, and then 16% have gone for A. Good. Okay. So the answer here is this is B. Yeah, good. So this question is mainly talking about peripheral neuropathy, which I think a lot of you have figured out, which is good. And basically, you've got someone who has hypertension, gout, and pulmonary TB. And then, as most of you figured out, pulmonary TB, you may be on isoniazid, which is a relatively common cause of peripheral neuropathy. But the most important, most likely in any case, is diabetic neuropathy. But in this scenario, in SBA world, the fact he doesn't have diabetes, we have no reason to believe he does, and he has a very clear risk factor, you would consider this patient to probably have isoniazid toxicity. And yes, despite it being treated 1 year ago, someone is saying, and the reason for that is because it can be long lasting. And it's out of several months, so it can just sort of keep going and can be irreversible. Vincristine is used in chemotherapy, and it is again a very common cause of peripheral neuropathy. Motor neuron disease is less likely because it's motor, not sensory, and Guillain-Barre wouldn't really have that sort of chronic picture. It tends to be very, very acute. Cool. Okay. So peripheral neuropathy. So again, you can divide peripheral neuropathy into sensory, motor, and motor. Sensory tends to be the most common ones. Motor is the more sort of rare ones, especially the pure motor ones. And that tends to be things that are really niche. The two things that are really niche are lead poisoning and Charcot-Marie-Tooth. I think pure motor, but actually super niche. On the most part, you'll have sensory and sensory motor. So with drugs, as I said, ask about chemotherapy and TB drugs, of course, but the chemotherapy is the sort of most common one. And then there are certain blood tests you need to do. And it's just sort of general stuff. So Fulglucan, Usnease, ESR, so I put ESR twice. B12 and folate are very important. And protein electrophoresis, that's for myeloma. if you know, and ANA and ANCA because you can get sort of vasculitis. A really good mnemonic that I've always used whenever anyone's ever asked me, it's useful for OSCEs because you can just say this mnemonic, is ABCDE, alcohol, B12 folate, CKD, diabetes, and then everything else. And it's just a nice, quick mnemonic. And the last thing I want to say is about Romberg's test, because Romberg's test is something that people don't really understand very much. The idea is that Romberg's test is used to differentiate between sensory loss and cerebellar dysfunction. And the idea is that if you have cerebellar dysfunction, so what you do is you get the patient to stand up, and then you check if they're dizzy, and then you ask them to close their eyes, and then you see if they get more dizzy. And the idea is that if they stand up and they have a cerebellar dysfunction, they will, sorry, not dizzy, unsteady. If they stand up and they have cerebellar dysfunction, they'll be unsteady regardless of whether or not their eyes are open or closed. However, if they have a sensory loss or sensory dysfunction, when their eyes are open, they have that visual feedback. So therefore, they will not be unsteady. But once they close their eyes, they become very, very unsteady. So the idea really is that you're checking to see whether or not they have sensory dysfunction. So a positive Romberg's test is indicative of a sensory loss, which tends to be associated with peripheral neuropathy. Whereas a cerebellar dysfunction, you just become unstable whenever, basically. So that's the sort of distinction between them. That caused me a lot of confusion when I was at university. Good. See if there's any questions. Fine. Okay. Okay, next question. Yeah, hopefully some of these are straightforward, and then maybe there's some harder ones as well that, yeah, depending on where you are at university now. Not where you are, but like where you are in your career trajectory, not the different universities. Okay. Okay, right, let's see what people think. Excellent, thank you. So 72% have gone for the oculomotor nerve, D, and then 18% have gone for A, and then, yeah, a mix of 6, 2, and 2. Good, okay, so stop that, and let's see. So the answer is also for oculomotor nerve, which is fine, but I think most of you sort of understand it. So the idea is that the oculomotor nerve is responsible for most of the eye movements. So that's the third nerve. The only two things that it doesn't really do is it doesn't abduct the eye, which that's the sixth nerve, and also it doesn't sort of doesn't move it down medially. So therefore, which is the fourth nerve, the abducens nerve. So if the third nerve isn't working, the other nerves sort of take control. So the sixth nerve will move it out, and then the fourth nerve will move it down. So that's why you get a down and out pupil in someone who has a oculomotor nerve dysfunction. And you've got someone who's got a tumor and is probably pressing on the oculomotor nerve. But the key distinction, which is the sort of next step, which is not really discussed so much in this question, but is a very important point, you may have questions on that, is that the pupil is very, very important. And the idea really is that if there's a problem with the pupil, it's more likely to be what we call a surgical cause, whereas if there's no problem with the pupil, it's more likely to be a medical cause. And the reason we call them surgical versus medical is because surgical causes are like tumors and aneurysms that tend to be, you know, something that may need to be taken out, for example, whereas medical causes are things that, you know, tend to be treated medically. So, and the reason for that is that because on the top of the nerve, you have the parasympathetic neurons, whereas in the middle of the nerve, you have the motor neurons. So in a surgical cause that's pushing down, it affects the parasympathetic neurons, and therefore you have the larger pupil. Whereas in a medical cause, it tends to be sort of more intrinsic within the actual, whereas as in terms of medical cause, it's more in the middle, and therefore the pupil remains unaffected. And basically the idea is that the surgical ones tend to be the source of the more emergency type stuff, whereas the medical ones tend to be things that you don't need to worry about as much, in terms of like acute need for surgery or whatever. So that's so always when you're looking at oculomotor nerve dysfunction, look at the pupils and make an assessment if it's a surgical or a medical third nerve palsy. So we talked about that. The last thing I want to talk about is the sort of some causes of the ophthalmoplegias, which is a very broad term. And basically, the internuclear ophthalmoplegia is a term that is commonly associated with multiple sclerosis. And basically, it is the effect. So there's a lesion in what is called the medial longitudinal fasciculus, which essentially affects the coordination between the third, fourth, and the sixth nerves. And what happens is that what you see in front of you is that one of the eyes, so this bottom picture on the bottom left, one of the eyes is unable to adduct, and then the other eye has nystagmus. There's a lot of documentation and literature about actually why that happens, and you can feel free to read up on it if you want to, but I always found it really confusing. So to be honest, I never really bothered to learn why exactly that happens. I just remember it as it's a disruption in the connection, and then you see an inability to adduct and also nystagmus in the other eye. And kind of that's all you need to know, but you can read up on it if you really want to. And then the last thing is very important is that the sixth nerve palsy is very important because it is what is called a false localizing sign, which can be associated with raised intracranial pressure. So the idea here is that the sixth nerve has a very long intracranial course. So therefore, if you have raised intracranial pressure due to a tumor or a bleed or something, then it is most likely to affect the sixth nerve palsy. So if you have a sixth nerve palsy that's isolated, you need to act quickly just in case the patient has raised intracranial pressure. And that's why they call it a false localizing sign, because it localizes to the sixth nerve, but it doesn't, because it's a reflection of the general pressure in the brain. So that's why it's a bit not very intuitive. So yeah, and then finally, fourth nerve tends to be associated, it's quite rare, but trauma, multiple sclerosis. Essentially, multiple sclerosis can affect any cranial nerve for the most part, because it affects any part of the central nervous system. So we'll talk about that in a bit more detail later. Okay, next question. Cool, right, let's see what people think. Okay, nice, very, yeah, nice spread, good. Let's get everyone in, the answers. Cool. Okay then. So we have 52% have gone for A, and 43% have gone for B, and then yeah, 5 and 1%. Good. Okay. So I'm going to stop sharing there. So a mixed bag of things, and the answer is in fact acute stroke, actually. Cool. Okay, so this is a good learning point. Hopefully you'll gain a lot from this. So basically, this patient with unilateral facial droop 6 hours ago and no other symptoms. And basically, the key finding, it's weird because it can be quite subtle, and if you're not looking for this particular finding, you may just sort of think it's not very important. But the key, literally the whole thing is about these two words, which is forehead sparing. And the idea really is that if you have evidence of forehead sparing, that is indicative of a upper motor neuron lesion. Whereas if the forehead is not spared, I'll show you a picture about it to make more sense, then it's more likely to be a lower motor neuron lesion, which would be the rest. So Bell's palsy so Bell's palsy and cholesteatoma would be consistent with lower motor neuron lesions, so it's less likely. Space occupying lesion, it's not correct because it's usually not sort of 6 hours, it's usually months, and conversion disorder not relevant here. So let's just look at pictures to make more sense. So basically what you do, so this is a patient with Bell's palsy. So the idea here is that you've got the, I don't know if you guys can see my mouse, but if you can, you've got the facial nerve coming all the way out, and if you cut it or it's not working, then you have the whole side just not working at all, and the whole side is off. So that you don't. That's a lower motor neuron lesion. Whereas if you have an upper motor neuron lesion, the forehead is actually supplied by both sides of the brain. So basically, if the forehead still works, that means it's an upper motor neuron lesion, and therefore it is something that is like a stroke or multiple sclerosis, something like that. Whereas if it's a lower motor neuron, these are the things that you would look at. So Bell's palsy is a sort of idiopathic disorder where it just randomly gets facial nerve palsy and it gets better. Ramsay-Hunt is associated with herpes viruses, then other random stuff, Lyme disease, sarcoid, sometimes Guillain-Barre, and then parotid tumors that can extend into the facial nerve can cause it as well. One last thing about seventh nerve palsy is that sometimes you can get a nerve 5, 7, and 8 lesion, and that is associated with a cerebellopontine angle tumor. And that is a tumor that is in the brainstem that is affected 5, 7, and 8, and then it's like a classic sort of phenomenon that you see. So whenever you're checking anyone with a facial nerve palsy, you need to check the 5th nerve and the 8th nerve as part of your examination. Okay, cool. Next question. Bell's palsy. No one really knows why Bell's palsy, what the cause is of Bell's palsy. Yeah, acoustic neuroma can be a cerebellopontine angle tumor. Yeah. They think maybe infection, but they wouldn't be called a. Sorry, I'm going to let people answer this and I'll answer. Okay. Okay, cool. So people are seeing, so 89% have gone for B, which is levodopa, which is the correct answer. Just to answer people, someone's asking, why is it not an acoustic neuroma? It can be an acoustic neuroma. Basically, a cerebellopontine angle tumor is a tumor that is in the cerebellopontine angle, and one of the types of that kind of tumor is an acoustic neuroma. So it just is indicative of the area, but it's a neuroma be the underlying. Okay, fine. So with this question, you've got someone with, so the answer is, yeah, we said levodopa. So resting tremor, frequent falls, poor balance, and clearly you've got evidence of Parkinsonism, which is bradykinesia, rest tremor, and then, you know, the poor balance, that's sort of classic for Parkinson's disease. And then basically the question is, you know, what would you start off the patient with? And that tends to be levodopa, which is the first thing. When it starts, when you have motor symptoms that are affecting your quality of life, then you would start someone on levodopa, which is sort of dopamine replacement, because you have a destruction of the substantia nigra, which is usually releases dopamine. But the key things here is that you need to distinguish Parkinsonism from stuff that looks like Parkinsonism, which can be things like essential tremor, of which you can give propranolol for. But here, the difference is that in essential tremor, you may have a postural tremor, where you sort of lift your hand out and then you sort of you shake a bit. But in Parkinson's, you have a resting tremor, so when it only actually is seen when the patient isn't moving. The other stuff, deep brain stimulations, apomorphine, or ropinirole, are all things that you can give later on, and not really first line in Parkinson's disease. So if we talk about Parkinsonism as a syndrome, it's very important to distinguish between Parkinsonism and Parkinson's disease. So the key features are tremors, which again, we're talking about resting, and it disappears when the patient is actually moving or moving their hands. Rigidity, and you can have increased tone, associated with that. Bradykinesia, slowness of movement, and then postural instability, which you can see sort of sometimes you can see like a shuffling gait, for example. They have a difficulty with their sort of arm swing and they can't really turn properly. And basically, when you were talking about Parkinsonism as a syndrome, there are different causes. The most common cause is what we call Parkinson's disease, also known as idiopathic Parkinson's disease, which is associated with, it's sort of like the classic Parkinsonism syndrome, as it were. But there are other things, so vascular, so if you have strokes in the sort of basal ganglia, you can get Parkinsonism then. Drugs, so antipsychotics, can cause Parkinsonism. And then there are lots of Parkinson's plus syndromes, which you may have heard about, which are things like multi-system atrophy and what's the other one? I forgot what the other one was now. Does anyone know what the Parkinson's plus syndromes, the other ones are? Can remind me. PSP, there we go, yeah, progressive supranuclear palsy, that is correct. So someone's asking the difference between Parkinsonism and Parkinson's. So as I said, Parkinsonism is the syndrome, it is what you see in front of you, but Parkinson's disease is one of the causes, so that's why. Yes, thank you, Lewy body dementia as well. I don't really like talking about Parkinson's plus syndrome, mainly because people tend to hone on it a lot and focus on it and trying to memorize stuff about it. The main thing that you need to know about Parkinson's plus is that it sometimes has atypical features of Parkinson's, one of which is that it is not really well treated by levodopa. That's one of the signs. Also, you can have quite significant sort of early disease that gets worse very quickly. And then you can have sort of other findings like balance problems and things like that, and cerebellar dysfunction. And clearly someone is saying with Lewy body dementia, and that is associated with a quite significant sort of dementia element, even though dementia is associated with Parkinson's disease itself. And one thing is that Parkinson's disease is asymmetrical, which tends to be only on, in terms of a tremor, on one hand, whereas some of the other causes, particularly the drug causes, tend to be sort of bilaterally. So that's a nice sort of distinction between them if you ever have a question on it. And then one way to distinguish between essential tremor and Parkinsonism is to get them to write, which is very, very important. So I think I've got an image on that. This is very interesting. So this is called the tremulous hand of Worcester, which is a very old document that was found. It's in Oxford at the moment, and you can see here that this person is tremulous, and then they think that he had essential tremor. And does anyone know what the sort of, in contrast, what Parkinson's disease patients, how their writing is by any chance? You may have come across it. Yeah, right. So micrographia. So micrographia is associated with Parkinson's, whereas essential tremor is more like a sort of it's quite clearly sort of tremulous, and the lines really aren't very clear. So that's the sort of distinction between Parkinson's and essential tremor. And you can say that even in your OSCE, for example, if you have someone with Parkinson's, what would you do next? Oh, I would get them to write, for example. So yeah. Fine, management of Parkinson's. So as I said to you earlier, levodopa tends to be first line. You offer levodopa in patients with Parkinson's disease, and it's mainly the motor symptoms that it helps to affect. But as you know from your neuroscience and neuroanatomy days, that dopamine has a big effect on lots of different parts of the brain. So there are certain drugs that you can give, which unfortunately can affect different parts of the brain. So for example, if you give someone a dopamine agonist, you may increase the amount of dopamine in the rest of the brain and can affect things like the reward and pleasure pathways, and in some cases can lead to sort of quite unruly behavior or behavior that is unusual. So for example, people might start gambling, people might start being reckless. So it's quite important to make sure that people are aware of the possible behavioral changes when you're giving things like dopamine agonists. But the most important is to know about is levodopa. One of the issues with levodopa is that it tends to wear off, and it is you can get these sort of on-off effects, and it can be quite bothersome for patients, and it just stops working over time. So in the past, they maybe used to sort of not give it too early, but at the moment, I think the feeling is if it affects your quality of life, then you give it, and then you try other stuff. And as you can see here, you don't need to know too much about the rest of the stuff, but MAO-B inhibitors, selegiline, you can give subcutaneous apomorphine, which has a dopaminergic effect. And if things are really bad, you can consider deep brain stimulation, which the mechanism of how it works is not really well known, but it tends to sort of somehow disrupt the pathways in a way that stops you from having the symptoms, but no one actually knows exactly how it works. And this was my knowledge like 5 years ago when I was doing my intercalated BSc, but maybe things have changed, we have more knowledge, but as far as we know, we don't. Cool, okay, next question. Okay, cool. Let's see what people think. Right. Cool. Okay then. Someone's asking the role of antimuscarinics for Parkinson's. Yeah, it can sometimes help with tremor. And yeah, they tend to be used a lot in drug-induced Parkinson as well. But I think, as far as I understand, I think a lot of it is mainly for the tremor rather than the actual motor symptoms. I think that's my understanding at least. Cool. Okay. So 73% have gone for C, which is, I think it's the correct answer. Let's check. Yes, it is C. Cool. Okay. So 34-year-old woman with weakness, and instantly you should be thinking, okay, there's this multiple sclerosis. Okay, let me see if the rest of it agrees with me. And then she's got spastic paraparesis, brisk knee ankle jerks, upgoing planters, upper motor neuron, probably still multiple sclerosis. She had some previous disturbance in her right leg, and then 4 to 5 days, she thought it was sciatica, doesn't look like it. And then MRI helps you to tell you sort of what this is. There's some white matter plaques all around the brain and the spine. So the next best step is going to be to try and reduce the inflammation in this patient's body. And then if you have an MS, multiple sclerosis flare, you treat the patient with methylprednisolone. So acyclovir is for viral infections, you wouldn't give that. Plasma exchange, not really used for multiple sclerosis, and it can be used for some inflammatory conditions, but not first line, especially if you're not treating a flare in multiple sclerosis. Lorazepam, not very helpful here. You use it for seizures. Natalizumab can be used in multiple sclerosis later on. So I've just put this little sort of diagram just to show you the different types. So you can get relapsing and remitting, that sort of, you get really bad and then you improve, you get really bad, you improve, and you don't have new disability. But that can sometimes then convert itself to secondary progressive multiple sclerosis, and sort of get more progressive, which is the least common type, and kind of can affect sort of younger people and can be quite severe. Primary progressive just gets worse and worse and worse and worse, and the treatments are less for that one. Cool, multiple sclerosis. So as you can see from this image on the right, you can just have lots of little bits of the brain that are affected, and it is an inflammatory disease. And then the most important thing that you need to know is that it affects the upper motor neuron only, central nervous system. It cannot affect the lower motor neuron, cannot. If you have lower motor neuron signs, it's not MS, basically, unless you have something else with MS. So the presentations can be quite varied because it can affect anywhere in the nervous system, or the central nervous system rather. So you can get sensory loss, you can get optic neuritis, which is loss of vision, but also pain. Pain is very important. We've talked about internuclear ophthalmoplegia, cerebellar dysfunction, and then what this lady had was spastic paraparesis, which basically means that sort of you're affecting the cord itself, and then you get both legs are not working. And the way that you make a diagnosis is obviously by the history first. You do an MRI, and there's a certain criteria called the McDonald's criteria, which helps you to differentiate between so basically it tells you that you have to have lesions separated in time and space. So you basically have to show that there are different areas of the brain that are affected in different times, because sometimes you have just one lesion which can be associated with something called ADEM, which is acute demyelinated encephalomyopathy or something like that, encephalomalacia. But basically, you have to have different times or different areas, so it can't just be the one time. So that's why you always have to ask if it's happened before you make the diagnosis of MS and commit them to inflammatory drugs that may cause more harm. And also you do a lumbar puncture, and with that you need to do oligoclonal bands, and then you need to compare that to the blood. So you need to check the oligoclonal bands in the CSF, cerebral spinal fluid, and compare the amount to the blood and whether or not there's more in the CSF compared to the blood. Okay. So fine. What if someone's asking, what if it's the first attack? It's the first attack. You don't usually start them on a sort of long-term disease-modifying therapy. You may just give them steroids to help things reduce, and then if they have another attack, then you do another MRI. And you see, according to the McDonald's criteria, that there's different lesions in time and space, and then you may make a diagnosis of multiple sclerosis. So with the management, we talked about corticosteroids, but also when you have someone with an acute relapse, you need to also rule out things like a urinary tract infection, medical problems, because those are the sort of things that sometimes can trigger relapses. So you need to also do a thorough assessment otherwise. There are other disease-modifying agents that you can give. So beta interferon, fingolimod, natalizumab, all very niche. You don't really need to know about them too much. There's one of them, so the more severe anti-inflammatory drugs can cause this PML, which is sort of primary multifocal leukoencephalopathy, which basically is a reactivation of a virus. So there's a virus called the JC virus, because the first patient that had it was a guy called John Cunningham. And basically, it's a virus that lots of people have and doesn't really affect you in any way. But in certain patients who have disease-modifying agents, especially the more sort of strong ones, it can reactivate the virus and lead to this syndrome called PML, which can lead to a lot of damage to the brain and essentially irreversible. So that's one of the risks you take when you give these medications. And then very important, when you're talking about multiple sclerosis in an OSCE scenario, you need to talk about physio, make sure to monitor their mental health, because depression is very common in this group of patients. Baclofen can be used as a symptomatic therapy for increased tone. And don't forget to mention the multidisciplinary team, the MDT. You can mention that first. So when you're talking about it, you always say, conservative, medical, surgical. That's the way you think about it. Okay, I think this is question 11. I don't think this is actually the right number. Maybe it is actually. Have we done 11 questions? Quite good. I think this is the last sort of 1-2 questions, I think. I think this might be the last question. Yeah, someone was saying you can diagnose at first presentation. Yeah, so if you have MRI lesions, old MRI lesions on the MRI, then you can diagnose on first presentation. That's right. Yeah, I was just saying that if you didn't, then that's how you would say. That's how you diagnose it. Sorry. Okay, cool. So what we got? So we got 80% have gone for B, and then 18% have gone for C, which is cool. Fine. So yeah, that is the correct answer. And then I think I just wanted to use this as a way of understanding how we think about patients with epilepsy. And I think most of you got it right, which is very, very good. So basically, you've got someone who has been seizing for a while. He's got a history of tonic-clonic seizures, and then he's having sodium valproate, but he's got alcohol excess, and he's been well in the days prior to his admission. And basically, the idea really is that if someone has a seizure, it's people. I think when you're in the emergency department, people always worry that the seizure is a cause of like a stroke or something, or a bleed or something, and therefore people do CT heads, which is fine. It's fair to do a CT head if someone's got a seizure. But if you've got someone with a long history of tonic-clonic seizures, having another seizure, it's probably more likely to be epilepsy, but you need to rule out other stuff. So in this scenario, one of the problems with using valproate and drinking lots of alcohol is that you can have a enzyme-inducing effect, and therefore it's less useful, and therefore you can have more seizures. And that's why it tends to be bad. So you need to, when you're investigating and taking histories from patients, that's why the social history is very important. You need to ask, do you drink a lot? Have you been having a binge recently? Have you been taking any new medications, et cetera, et cetera. So it's very, very important to take a very thorough history when you're investigating anyone in the emergency department. And then just with that in mind, there are certain types of seizure that we think about. It can be differentiated into focal and generalized. The difference between in focal, between complex and simple, is the fact that you lose consciousness in complex, and simple you don't. And then the generalized seizures, you may have heard of absence seizures, where someone just sort of stops talking and says nothing for like a minute or so and then goes back. Toniclonic is the sort of classic increased tone, and then they shake, and that's sort of classic seizure. And a myoclonic is when you have these myoclonic jerks. So the classic is, a young person in the morning, they wake up having some cereal, and then they have a myoclonic jerk, and they sort of, their hand jerks, and then they sort of throw the cereal onto the floor, which makes their family very angry, but because they're just throwing cereal on the floor, but actually it's because they're jerking. And then last is atonic, is when you just completely lose tone and then you just collapse, but clearly it's rare and more difficult to diagnose. And the last thing when you're thinking about seizures is that you need to also ask how they are. So things like poor sleep and tiredness and fatigue and these kind of things can affect seizures, and also metabolic disturbances. So the classic one that we need to worry about in a medical setting, which we need to address if it's very, very low, is hyponatremia. So check sodium level, because the risk of seizure is very high, especially if the sodium is very, very low. And that may require an ITU admission if things are really bad, if they're really low from a sodium perspective. And yeah, so in terms of management of epilepsy, the ones that are very important are lamotrigine, levetiracetam, and valproate tend to be very, very good. I think the thing about valproate, as you know, there's been lots of recent guidelines recently about how you can't really use valproate for people who have childbearing age, and there's lots of guidelines, lots of sort of important obstacles you have to go through if you want to prescribe it. And whereas there are certain seizures that are certain drugs are very useful for focal seizures, particularly carbamazepine. And then the last two is, so I've put some stuff now. I didn't read that. And then carbamazepine can actually worsen myoclonic seizures. I think the only one that's really sort of definite that we use is that just for absence seizures. So ethosuximide, that's sort of best drug for it. But everything else is sort of trial and error to a certain extent. So it's only really rules of thumb rather than sort of definite things that you use on the most part. Probably more important for you guys, if you're junior doctors, is that you will be expected to treat someone with status epilepticus. And basically, classically, it's thought to be seizures that are more than 30 minutes, but in practice, it's a seizure that is more than 5 minutes. And if that's the case, then you start treating. And the mnemonic that my friend, I think, created at uni is Lori, funny, call ITU. And this idea that you give lorazepam, 4 milligrams. If that doesn't work, you give another dose of lorazepam, 4 milligrams. If that doesn't work, you start a phenytoin infusion, and then you call ITU for general anesthesia. The only caveat I would say is that you may have seen this on the wards, possibly, is that a lot of time now they don't really use phenytoin in some places, because the NICE guidelines say that you need to use a phenytoin infusion, but practically phenytoin is more difficult to get hold of. It can be corrosive to the veins, and as a result, people tend to use levetiracetam more likely, because it's quite a simple drug and it's a very, it doesn't really have any side effects. And a recent study in the New England Journal of Medicine, which was led by actually one of the professors at St. George's, where I worked last year, showed that actually levetiracetam, phenytoin, and valproate were also equally useful for status epilepticus. So although the guidelines say phenytoin, in practice we also use different things, mainly related to the fact that they're work equally well. I think the guidelines might change in the next couple of years, so watch this space. Last question, which is challenging on localization, but also a bit of exam technique to help you sort of think through things. This is sort of pure neurology now, just sort of, you know, really thinking about what could it be. It's very hard. Don't worry if you don't get it right, just use it to learn. Yeah, hopefully it's useful. This is the last one. I'll give you another like 5 seconds or so, see what you think. Okay, good. So let's see what we think. So we've got a spread as well, which is fine. So, oh, there we go. 40% have gone for D, and then 30% have gone for B, and then the answer is in fact D. Okay, let's go through the question. So basically, if you walk through this with me, you've got someone with leg weakness. There's normal tone, and then there is reduced power bilaterally in the distal lower limbs. And the ankle reflex is absent bilaterally, but the knee reflexes are present, and then the plantars are upgoing. So which of the following signs is most in keeping with the diagnosis? So basically, you've got someone who has a mix of upper motor neuron signs and lower motor neuron signs. You've got the reduced power, which can be both. Ankle reflex is absent, that's lower motor neuron, but the knee reflexes are present, that's a bit equivocal, but the plantars are upgoing. So you've got the plantars upgoing is upper motor neuron. So if you have someone with upper motor neuron and lower motor neuron signs, you need to be thinking about motor neuron disease, because motor neuron disease, you may have heard of it, also called ALS, amyotrophic lateral sclerosis. It can affect the peripheral neurons, but also can affect the sort of slightly more central aspects close to the spinal cord and can lead to upper motor neuron lesions. So looking at the other stuff, pale optic disc, optic neuritis more likely in MS. This is less likely 60-year-old man. This should be sort of usually a younger woman. Also, you never have lower motor neuron signs in MS. We're clear on that. Positive Romberg sign is sensory, as we talked about, wouldn't be affected MND. Postural hypotension tends to be autonomic rather than motor in motor neuron disease. Internuclear Ophthalmoplegia. The eyes are really not affected very much at all in motor neuron disease. And again, we said it's more likely to be MS. So therefore, the wasting of the small hand muscles, which is also a lower motor neuron sign, is in keeping with the mixed picture, also common in motor neuron disease. So if you see upper and lower, think of motor neuron disease. So this is a mnemonic that one of my friends made at university, which is Fred's tabby cat seeks mice, which is basically a mnemonic to remember mixed upper motor neuron and lower motor neuron lesions. So Friedreich's ataxia, tabes dorsalis, which is syphilis, cervical spondylopathy, which is sort of when you have a lesion of the cervical spine, which can affect the root, which is lower motor neuron, and also the spinal cord itself, which is upper motor neuron, syringomyelia, motor neuron disease. All these are a bit niche, but actually I think it's just a nice way of just sort of remembering stuff. And then the only other one I would add is, so S is syringomyelia can also, and also subacute degeneration of the cord can lead to upper motor neuron, lower motor neuron lesions as well. So I just add that as an S. I'll add that for the next session. Okay. I've left this, if this is of use, the top 3 differentials according to neurological syndrome. I think this is helpful because it helps you to sort of think about the syndromes and then sort of think about how to make sense of it. So if someone asks you what the cause of spastic paraparesis is, you can just say the most common 3 causes are multiple sclerosis, cord compression, and stroke. And when I say spastic paraparesis, again, it's sort of when you have both legs, for example, not working because you have a cord lesion. Hemiaparesis is on one side, stroke, tumor, MS, Parkinsonism, idiopathic, vascular, and drugs, and then the other stuff. So hopefully that'll be useful for you going forward. And then, yeah, I've just left it for reference if that's of any use. Okay, I think that's it. Feedback, please.